let's go. My name's Keisha Ryder, a PA student here at the University of the Cumberlands. Just want to wash my hands real fast. And how are you today? Good. Okay, so I'm just going to check your patient identifiers. Jane Doe, date of birth, and hospital number. Okay, so everything matches. So you are here today for your skin exam and your head, ears, eyes, nose, and throat exam. Do you have any questions before we begin? Okay.
Okay, first you would prepare and discuss the skin exam. Ask about any changes in skin, hair, nails, any rashes, sores, lumps, itching, concerns about any moles, or history of melanoma or previous skin biopsy results.
Do you have any of the above?
No.
Okay. Before we go any further, I'm just going to place this gown on you.
You would gown patient for close inspection. Use natural lighting or intense lighting when needed. Then educate the patient on suspicious moles, skin care, and self-exam.
You'd always want to use the ABCDE method to check for melanoma.
Okay, next is the inspection of the skin. Ask about color change, look for increased pigmentation, loss of pigmentation, redness, pallor, cyanosis, or jaundice.
You do not have any of the above.
Next, you would palpate the skin. Check moisture, which is dryness, sweating, or oiliness. Check texture, roughness, or smoothness. Check temperature. Check with the back of your fingers on both arms. Check mobility, which is the ease of the skin to lift up. Check turgor, which is the speed it returns to normal. And palpate any lesions, location, or distribution of those lesions.
I do not notice any lesions or abnormalities.
Next, we're going to explain the inspection or palpation of fingernails or toenails. You're going to note color, capillary refill, and any cyanosis.
Normal capillary refill and no cyanosis.
You're going to note any lesions, pitting lines, or deformities.
No pitting lines or deformities or lesions.
Note shape or clubbing, which is the angle proximal nail fold and nail plate, which should be less than 180 degrees.
No clubbing, the angle is less than 180 degrees.
The next exam is the head exam. You're going to verbalize and demonstrate the exam of the head. Ask if anything is wrong with scalp or hair, and if the patient has a hairpiece, ask to remove this hairpiece.
Will you please remove your hairpiece?
Do not have one.
Okay. Do you have any lesions or abnormalities I should know about before we begin?
No.
Okay.
Okay, next you're going to inspect the hair. You're going to note the quantity, distribution, texture, and pattern of hair loss.
There's no hair loss and normal distribution.
Okay, inspect the scalp. You're going to note scaliness, lumps, nevi, or any other lesions visible.
No abnormalities visible.
Okay, you're going to inspect and palpate the skull. Note size, contour, lumps, tenderness, suture lines, or of parietal and occipital bones.
Parietal and occipital suture lines are normal, no abnormalities.
Okay, you're going to inspect and palpate the face. Note facial expression, asymmetry, involuntary movements, edema, or any masses.
No edema or any masses, normal symmetry. We'll begin the eye exam. To begin, the provider will check visual acuity with the Snellen chart. The patient will stand 20 feet from the chart and determine the smallest line of print that they can identify more than half the letters. This will be expressed as 2 numbers. The provider will check near vision with a handheld card or any available print held 14 inches away. This can identify the need for reading glasses. Next, the provider will perform visual fields by confrontation. It has the patient look into their eyes, places 2 hands 2 feet apart, lateral to the ears, slowly moves wiggling fingers toward line of gaze until patient identifies them. Normally, you should see both at the same time. Next, the provider will inspect position and alignment of eyes. They will stand in front and survey position and alignment. Next, it is time to inspect the eyebrows. The provider will note quantity, distribution, and any scaliness of underlying skin. Next is inspection of the eyelids. Notes width of palpebral fissures, edema, color, lesions, and condition of the eyelashes. Next is the lacrimal apparatus. Check the regions of the lacrimal gland and sac. Next, the provider will inspect the conjunctiva and the sclera. She will ask the patient to look up, to press both lower lids with the thumbs, and inspect the color and vascular pattern against the sclera. Look to each side and down. Next, using oblique lighting, the provider will inspect the cornea and the lens for opacities. Next, she will inspect the iris, noting markings that should be clearly defined. Next is the pupils, to inspect the size, symmetry, and shape. Next is the reaction of light. Next is to test the reaction of pupils to light. She will ask the patient to look into the distance, darken the room, and uses bright light. She will check for direct reaction and consensual reaction, which is in the opposite eye. Next, she will check for near reaction. If the reaction is questionable, she holds the finger 10 centimeters from the eye, look alternatively at it and into the distance, watches for constriction with near effort.
So you're gonna look straight ahead and then look at my finger. Good, constrict it.
Next is extraocular movements. She will make a wide H in the air. She leads the gaze extremely toward the right, right and upward, down on right, without pausing to the middle, to extreme left, left and upward, down on left. The patient will move their head to follow the finger. If needed, hold head in proper position.
Alright, so you just follow my finger, okay?
Next is convergence. The patient will follow the finger toward the bridge of the nose. Eyes follow objects 5 to 8 centimeters of the nose.
Just follow me.
Next is the discussion of upper palpebral conjunctiva. The patient will look down and the provider will grasp the eyelashes and pull down and forward. She will place an applicator 1 centimeter above the lid margin. She will push down on stick and raise the edge of the lid. She will not press on the eyeball and will secure the lashes against the eyebrow.
Pulling down right now. I'll use an applicator, flip light, and observe.
Next is the use of the ophthalmoscope with the lights dim. She will move the lens to the largest round beam and set the disc to 0 diopters and darken the room. She will keep the finger on the edge of the disc to focus the lens. She will hold the scope in the right hand to examine the right eye, and in the left hand for the left eye. She will firmly brace against the medial aspect of the bony orbit. She will have the patient look at a point on a wall.
So look straight ahead for me.
She stands 15 inches away and 15 degrees laterally. She will shine the beam on the pupil and look for the red reflex. She will place her thumb of the other hand across the patient's eyebrow. She will keep the beam focused on the red reflex and move in at a 15-degree angle toward the pupil. She will follow a blood vessel centrally. She will bring the disc into focus by adjusting the lens as needed. She will inspect the optic disc, retina, and vessels and move the head and instrument as a unit. Next, she will inspect the fovea surrounding the macula. She directs the beam of light laterally and asks the patient to look into the light.
Go ahead and look in. Good. Do this on the other side as well. Look into the light. Good.
Next is the ear exam. Now we will begin the ear exam. First, the provider will inspect the external ear, including the auricle and meatus. She will note any deformities, lumps, or skin lesions. She will inspect the ear canal using the largest speculum. She will straighten the ear canal, grasp the ear firmly, pulls up, back, and slightly away. She will hold the handle between the thumb and the fingers while bracing the hand against the patient's face to avoid unexpected movements. She will direct the speculum down and forward through the hairs, noting any discharge, foreign bodies, swelling, or redness. She will inspect the tympanic membrane while noting the color, contour, and cone of blood. She will identify the handle and short process of the malleus. Next, she will perform a whisper test. She will occlude one ear while standing 1 to 2 feet away. She whispers a combination of 3 numbers or letters, using a different combination on each side.
D-O-G.
Next, she will use the tuning fork to check for lateralization. She will set it into lock vibration by placing the base firmly on top of the head. She will ask the patient where she hears it. Will she hear it out of one or both ears? It is normally heard in the midline or equally in both. Patients with normal hearing may lateralize. Test only those with hearing loss.
I'm gonna set this on top of your head. Just tell me which side you hear it in, or if it's both.
Both.
Okay.
Next, she will check air conduction versus bone conduction. She will set it into lock vibration and place it on the base of the mastoid bone. Whenever the patient no longer hears the sound, she will quickly place it close to the canal. She will determine if she hears the sound again. Sounds heard longer through air. Air conduction should be greater than bone conduction.
You just tell me when you stop hearing it, okay?
Okay.
Do you hear it now?
Yeah.
Okay. We'll check the other side. Same thing.
Okay.
Do you hear it?
Yep.
Air conduction is greater than bone conduction.
That is the end of the ear exam.
Now we will begin the mouth and pharynx exam. First, they will start by inspecting the lips. You will observe the color, moisture, if there's any lumps, ulcers, cracking, or scaliness. Next, they will inspect the oral mucosa. If the patient wears dentures, please remove those first. Any lesions present, palpate those. Use a light tongue blade and note color, ulcers, white patches, or nodules. Then inspect the gums. Check for color, they are normally pink, and check the margins for swellings or ulcerations.
Okay.
Inspect the teeth. Note any missing, discolored, mishappen, or abnormally positioned teeth. Check for looseness with thumb or index finger if noted.
Do you have any loose teeth? Okay.
Inspect the roof of the mouth. Note the color and architecture of the hard palate.
Okay, it's pink and the architecture is fine.
And inspect the tongue and floor of the mouth by protruding the tongue.
Can you just stick your tongue out for me?
Note the color, texture, and symmetry.
Okay, can you raise your tongue out for me? Okay, color's a lot pink. Symmetry is the same on both sides.
And inspect the pharynx. Opens the mouth, do not protrude the tongue. Place the tongue blade down.
For me.
Ask the patient to say ah.
Can you say ah? Ah. Okay.
Note the rise of the soft palate. Note color, symmetry, exudates, swelling, ulcers, or enlargements.
The rise of the soft palate was normal and there was no exudates, swelling, or any other abnormalities.
And then we will do the nose exam. Okay. Now we will begin the nose exam. Inspects the anterior and inferior surfaces of the nose. Notes any asymmetry or deformity.
No asymmetry, no deformities.
Exerts pressure on the tip of the nose to widen the nostrils.
I'm gonna raise your nose up right here.
Tilt the head back and insert speculum, being sure to avoid the septum. Inspects the inside of the nose and avoids contact with sensitive nasal septum, noting color and if any swelling is present.
Normal pink color and there's no swelling.
Okay. Next, we will test for nasal obstruction. We will press on each ala nasi and ask the patient to breathe in.
You just press right here and breathe in for me. Okay, now can you do that on the other side? Okay, no nasal obstruction.
Okay. Lastly, palpate the frontal and maxillary sinuses. Press the frontal sinuses from under the brows and maxillary sinuses for tenderness.
Any tenderness? No. Okay.
Okay, now we will begin the neck exam and palpation of the lymph nodes. We will palpate the nodes in sequence, noting size, shape, discrete or matted, mobility, consistency, and tenderness. First, starting with the preauricular in front of the ear, postauricular in the mastoid region, occipital at the base of the skull, tonsillar at the angle of the mandible, submandibular midway between the angle and tip of the mandible, and submental. While bracing the top of the head with the free hand, it's typically midline, a few centimeters behind the tip of the mandible. Superficial cervical, superficial to the sternomastoid. Posterior cervical, anterior edge of the trapezius. Deep cervical chain, sometimes inaccessible, but hook thumbs and fingers around either side of the sternomastoid muscle to feel. And lastly, supraclavicular, angle formed by the clavicle and the sternomastoid. Okay, so now we will perform the thyroid exam. The provider will be doing this from a posterior approach, initially inspecting and palpating the trachea. They will identify the thyroid cartilage, cricoid cartilage, and note the trachea and any deviation from a midline position. They will place the fingers along one side and note the spaces between the trachea and the sternomastoid, and it should be symmetric. Then they will palpate the thyroid gland, again from a posterior approach. Ask the patient to flex their neck slightly forward and relax those sternomastoid muscles. Then they will check the isthmus. They will place fingers of both hands on the neck so that the index fingers are just below the cricoid. Then they will ask the patient to swallow.
Can you swallow for me? Okay.
And they will feel the isthmus rise and fall under the finger pads. Lastly, they will palpate the thyroid gland by displacing the trachea to the right with the left hand
Push to the left, right
and palpates laterally, and then do the exact same on the other side.
hand. Push on this side for your left.
They are noting the space between the trachea and sternomastoid bone. And that will be all.
Okay, for the thorax and lung exam, first we're going to gown the patient.
Since you are a female, we're going to expose your entire posterior chest. Whenever we move on to the anterior chest, we're going to drape one half at a time. If you were a male, we would expose the entire chest, both posterior and anterior.
Okay, next we are going to survey for respiration and thorax. So first we assess color for cyanosis,
There's no cyanosis.
listens to breathing for possible audible wheezing,
There's no audible wheezing with normal respirations.
inspects neck for contraction of accessory muscles.
No accessory muscle use.
Okay, next is inspection. You're going to instruct the patient to assume the sitting position. Ask patient to fold arms across chest and rest hands on opposite shoulders.
Will you fold your arms like this?
Inspects from a midline position behind patient. Inspects the shape of the chest for increased AP diameter, which could be evidence of possible COPD.
There is not an increased diameter.
Next is palpation. We are going to palpate any painful areas if indicated.
Do you have any painful areas? Okay.
Palpate any lesions if indicated.
Do you have any lesions to palpate?
Or palpate any obvious abnormalities.
I don't notice any obvious abnormalities.
Next, you would palpate the posterior chest expansion. Place thumbs level with 10th rib position, hands parallel to lateral rib cage. Raise loose skin fold of skin between thumbs. Ask patient to inhale and feels for range of symmetry.
Will you inhale and exhale? Posterior chest expansion is symmetric.
Next, you're going to palpate for tactile fremitus. Places ulnar surfaces of the hands to compare symmetric areas of lungs. Ask the patient to repeat 99. Fremitus would be more prominent in the interscapular areas.
Will you say 99?
99. 99.
Next, we are going to percuss. You would percuss the posterior chest, stands to the side, percusses twice in each location, comparing two symmetrical sides in ladder-like pattern. Next, you're going to percuss diaphragmatic excursion. You're identifying the level of dullness during quiet respirations. Then you determine the distance between dullness on full inspiration and expiration, which is normally 3 to 5.5 centimeters.
Here's the level of dullness. Will you please breathe in? Okay. Approximately 3.5 centimeters, so it is normal.
Next, we are going to auscultate. You're going to position the patient with arms folded across chest and hands resting on opposite shoulders. Verbalize and instruct patient to breathe deeply through open mouth. Verbalizes and demonstrates correct method of listening to breath sounds, using ladder-like pattern to compare sides using the diaphragm of the stethoscope. Listen to at least one full breath in each location.
I'm going to have you breathe deep breaths.
Now we are going to assess transmitted voice sounds. The first test is to assess egophony. You're going to have the patient say E, states that a normal sound that would be heard is a muffled long E sound. If the test was abnormal, you would hear a nasal quality of E heard as A during the egophony presentation. Possible lobar consolidation is a possible abnormal finding for pneumonia.
Each time the stethoscope is placed on your back, please say E.
E, 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 E.
Test is normal.
The next test that's performed is the whispered pectoraliquy test. You're going to ask the patient to whisper 99. A normal finding would be faint and indistinct if heard at all. An abnormal finding would be a louder, clearer sound called whispered pectoraliquy.
This time will you whisper 99?
The last test to be performed on the posterior chest is to assess bronchophony. You're going to ask the patient to say 99. A normal sound would be a muffled or indistinct sound, and an abnormal sound would be louder, clearer voice sounds, which are known as bronchophony.
This time will you say 99?
99. 99. 99. 99. 99.
Now we will begin the exam of the anterior chest. First, they will instruct the patient to assume the supine position with arms slightly abducted.
Just leave your arms to the side.
Then they will inspect the anterior chest, observing shape and movement of chest wall or accessory muscle retractions.
Normal movement.
Palpating. They will palpate tender areas if indicated,
Do you have any tender areas or lesions that we should know of?
No.
Okay.
and palpate any noted abnormalities.
No abnormalities noted.
They will assess anterior chest expansion, placing the thumbs along the costal margins with hands on lateral rib cage. Raise skin fold between thumbs and ask patient to inhale deeply.
Just breathe in for me. You can exhale.
They will observe the extent and symmetry of movement.
Normal symmetry.
They will then perform tactile fremitus of anterior chest by placing ulnar surface of hands to compare symmetric areas of the lungs and ask the patient to repeat 99.
Can you say 99 for me?
99, 99, 99, 99.
Okay.
Then they will move on to percussion and perform correct technique for percussing anterior chest, being sure to stand to the side, compare two symmetrical sides in a ladder-like pattern.
Okay.
The heart normally produces an area of dullness left to the sternal border. Lastly, they will auscultate. They will instruct the patient to breathe deeply through an open mouth. They will demonstrate the correct method of listening to breath sounds using a ladder-like pattern to compare sides using the diaphragm of the stethoscope, listening to at least one full breath in each location.
When I touch you with the stethoscope, just take one full deep breath in for me. Okay, the first breath sounds that we're going to discuss are vesicular breath sounds that are going to be heard over most of the lung fields. These are soft and low-pitched sounds. The inspiration is longer than expiration, and the sound fades about 1/3 of the way through expiration. The next breath sound that we're going to discuss is bronchovesicular breath sounds, which are best heard in the first and second interspaces on the anterior chest and between the scapulae on the posterior chest. The intensity and pitch and inspiratory and expiratory are the same equal length, at times separated by a silent interval.
Tracheal breath sounds are best heard over the trachea and the neck. They are very loud, high-pitched, and harsh sounds. Inspiratory and expiratory sounds are equal in length. And so now to begin adventitious breath sounds, we're going to begin with rills and crackles. These are suggestive of normal abnormalities in the lungs or airways, such as pneumonia or congestive heart failure. They're discontinuous, intermittent, non-musical, and brief, so you can think of them such as Dalton Tom. You have fine rills and crackles, which are soft, high-pitched, and brief, and coarse rills and crackles, which are louder and lower-pitched.
Okay, lastly for the adventitious breath sounds, we'll begin starting by talking about wheezes. They're typically higher pitched, continuous, musical, prolonged, and they're more like dashes in time. They do have a hissing or shrill quality to them, but it's not necessarily throughout the cycle, and these could be indicative of narrow airways such as in COPD or bronchitis. And then lastly, you could have rhonchi, which are lower pitched, continuous, prolonged, and like dashes in time. This time they have a snoring-like quality and not necessarily heard throughout the cycle, and this can be indicative to secretions in the larger airways.
So now we're going to locate some anatomical findings on the anterior chest. First, we will locate the sternal angle. It is 5 centimeters down from the suprasternal notch to a horizontal ridge joining the manubrium of the body of the sternum. The provider will move laterally to the adjacent second rib, then walk down to the second interspace. Now for some posterior landmarks. To begin, the provider will locate the 12th rib, presses in and up against the lower border of the 12th rib, and then walks up the interspaces. Next, you will locate the inferior tip of the scapula, which usually lies at level of the 7th rib or interspace. T7, T8 is used as the landmark for thoracentesis. And next, she will locate the spinous process of C7. This is the most prominent. She will walk down to the 12th rib or interspace. Next, we will locate some more findings of the chest. First, you have the mid-sternal line. Next is the midclavicular line, which drops vertically from the midpoint of the clavicle. You have the anterior axillary line, which drops vertically from the anterior axillary fold. Then you have the mid-axillary line, which drops vertically from the apex of the axilla. The posterior axillary line, which drops vertically from the posterior axillary fold. You have the vertebral line, which overlies the spinous processes. And the scapular line, which drops from the inferior angle of the scapula.
Okay.
Next, we will locate some more anterior findings. You have supraclavicular, which is above the clavicles, infraclavicular, which is below the clavicles, interscapular, which is between the scapulae, infrascapular, which is below the scapulae, bases of the lungs, which are the lowermost portions, and the bifurcation of the trachea into mainstem bronchi, anteriorly at the sternal angle, and posteriorly at T4 process.
Now we'll begin the cardiac exam. The provider stands at the patient's right side, places the patient supine,
Will you lay back?
and make sure the head of the bed is at 30 degrees. Then the provider will begin by examining the carotids. They will inspect the neck for carotid pulsations, which may be visible medial to the sternomastoid muscle. They will then palpate the carotids by placing the index and middle fingers in the lower 1/3 of the neck, just inside the medial border of a relaxed sternomastoid muscle at the level of the cricoid. They will be sure to avoid the carotid sinus, which is found at the level of the top of the thyroid cartilage. They will then evaluate the carotids for bruits and auscultate, having the patient hold their breath using the diaphragm of their stethoscope near the upper end of the thyroid cartilage below the angle of the jaw. This is where the carotid bifurcates.
You flex your head slightly toward the side and breathe in and hold it. Okay, you can exhale. And the same for this side. Okay.
Next, the provider will inspect the chest wall. They will locate the mid-sternal line, mid-clavicular, and axillary lines.
Anterior, raise your arm up, mid, and posterior axillary lines.
They will then inspect the anterior chest for location of the PMI, if it's possible, and potentially use tangential lighting to make it more visible.
Now we will begin to palpate the chest wall. To begin, we will palpate for thrills and heaves in the aortic, pulmonic, left sternal border, and apical areas. Point of maximal impulse is a brief, early pulsation of the left ventricle touching the chest wall. The provider will locate the point of maximal impulse in supine position or use left lateral decubitus position if needed. She will palpate with palmar surfaces of several fingers, then go down to one fingertip for finer assessment. The PMI's vertical location is in the 5th intercostal space and horizontal distance from mid-sternal line. Now we will begin with auscultation. Both the diaphragm and the bell is used. The diaphragm is placed firmly against the chest for high-pitched sounds. The bell is placed lightly against the chest for low-pitched sounds. To begin, she will auscultate the aortic area, which is the second right intercostal space, with the diaphragm and with the bell. Next is the pulmonic area, which is the second left intercostal space, with the diaphragm and with the bell. Next is the tricuspid area, which is the left lower sternal border, with the diaphragm and with the bell. Last is the mitral area, the apex, with both the diaphragm and the bell. patient will be placed in the left lateral decubitus position to auscultate with the bell to listen at the apex for possible low-pitched sounds of mitral stenosis.
So I'm gonna have you like half turn on your left side. That's perfect. No mitral stenosis noted.
The patient will sit and lean forward after full exhalation. The provider will auscultate with the diaphragm along the left sternal border to evaluate aortic murmurs.
So I'm gonna have you lean forward and blow out and hold it. Go ahead and blow out. No aortic murmurs noted. Now we will palpate the peripheral pulses, beginning with the brachial, which is medial to the biceps tendon. Then the radial, which is lateral to the flexor surface. Then the ulnar, which is medial to the flexor surface. Then femoral, which is below the inguinal ligament. Popliteal, which is behind the knee medially. Dorsalis pedis, which is lateral to the extensor tendon. And posterior tibial behind the medial malleus. And we will check the pulses on the other side, again beginning with brachial, then radial, then ulnar, femoral, popliteal, dorsalis pedis, and posterior tibial. That completes.
Okay, do you have any questions for us?
No.
Okay, your exams are complete. We'll see you back in a little bit.